Good afternoon or good morning, everyone. My name is Michelle Brunson. I'm a Health IT Advisor here at Telegen, and I'd like to welcome you today. Thank you so much for joining us for the Developing Provider Collaborative Care Agreement. We are very lucky today. We have a special guest presenting for us today, Pamela Ballou-Nelson. She is a Principal Consultant with the MGMA, which is a partner of the QPP-SURS program. We're lucky to have her on our team. Pam is an RN with a BSN in Nursing from the University of Utah, an MA in Communications from Wheaton College, and an MSPH and a PhD in Public Health from Walden University. Her 35-plus years of varied experience in healthcare settings have resulted in a strong, comprehensive understanding of healthcare policy and practice, participating in many healthcare challenges and changes over those 35 years. Her skill set covers public health, population health, patient activation, ambulatory practice management, clinical quality measure development and compliance, health system transformation, informatics, leadership development, and extensive educational and mentoring involvement with medical staff and community. Pam currently works as a principal consultant with MGMA, assisting healthcare systems with process improvement, clinical integration, PCMH, ACO transformation, and MIPS compliance. So we're very fortunate to have Pam on our team. And so before she starts today, I want to draw your attention to a couple things. First of all, the slides are available for download on our TelegenQPP.com website. I have placed the link for the slides in the chat function there, so that'll take you directly to those, or you may go to TelegenQPP.com and under resources, click on webinars, and you'll see the webinar date there, and just click on the slides for download. Also, at the end of the webinar, you will be, a survey will pop up, and we ask that you please take the time to complete that. That really helps us in understanding how we are doing, and if there are other webinars you would like to see or need any additional assistance. So we appreciate the time that you take to do that as well. So with that, welcome Pam, and thanks again for presenting for us today on this very important topic.
Thanks, Michelle, and welcome everyone. I trust everyone is surviving the cold and snow of the Midwest. I'm sitting here in Colorado and delighted to inform you we're going to be sending more snow your way, as it's snowing for us today. So if you're a skier, the skiing is great. So come on out and join us. And hopefully you're not freezing too much out there. I hear the temperatures have been pretty cold. So what we're going to talk about today, see if I can get the slides to cooperate with me here. There you go. So we're going to talk about developing the Provider Collaborative Care Agreement. So our objectives here is to define the care compact and its role in the optimal care outcomes. We want to identify steps that are involved in developing an effective care compact, and we're going to talk a little bit about how we include the patient in this care compact. And I know it sounds like this is extra work, especially when we know we already have a lot to do. But I think you will find that there's many aspects of what we're going to talk about today that are already part of your workflow. We just need to be able to coordinate them in a meaningful way that will improve those communications. So why do we want a care compact? And you'll see that there's probably other names for this care compact as well. But why do we need this? It provides a framework for better communication, for safe transitions of care. And it's not just between the primary care and the specialty providers, but it may also be between two specialty providers, like an ophthalmologist recently referring to a retina specialist and looking at a care compact. The care compact then, the result is for optimal health outcomes for the patients. And we know that we're always striving in healthcare today to improve outcomes and to decrease those costs. And so this care compact is a way in which we can do that. And what it does is it brings together primary and specialty care, or two specialty cares, for the benefit of the patient. It's a formalized agreement between the PCP and the specialist, or two specialists. And it also designates referral protocols, care transition expectations, care management responsibility. Who's responsible for what? Care compacts are very critical if you're part of an ACO or some sort of clinically integrated network where you're dealing with population health, and you may be involved in risk contracting. So care compacts are critical in those situations. We know that the average Medicare patient sees 7 different physicians, which include 5 different specialists in a given year. If a patient has multiple chronic conditions, the count can go as high as 11 to 16 different physicians in a given year. So you can see from this that it is imperative that we have some form of communication between all of these providers. I work a lot with patients and consumers in terms of surveys and interviews, and one thing that I hear a lot from patients with multiple chronic diseases is that the providers don't talk to each other. One provider may tell the patient one way to do something, the next provider tells them another way, and this presents a lot of confusion and misinformation on the part of the patient. So the idea of this compact is simply a process that defines and documents the expectations that physicians have regarding what they're going to receive from each other, what that expectation is, and articulates who is going to offer what services to the patient, and also to make sure that we're including the patient in this dialogue as well. So this effective communication between the providers will eliminate waste and the excess cost of healthcare. So it used to be that clinicians saw each other in the hospital. They chatted with each other at the doctor's lounge. They received their referrals and information in their inbox in the doctor's lounge, where most of these scenarios don't exist anymore, and so we struggle with effective communication. Care was not as diverse in those days. It was not as complicated. We did not have the restrictions by the payer as to where a patient was to go to labs and where a patient was to go for their imaging. So all of these opportunities and diversity in healthcare have created a communication barrier that we have not really effectively penetrated as yet. And so that care compact is to be able to provide that communication so that we don't have these gaps in care and waste. You know, a recent article in Foresight Health stated that by 2020, medical knowledge will double every 73 days. With all this knowledge, effective communication is really critical. And so this is not a prescription. The Care Compact is not a prescription to tell the specialist how they should do their job, but it is just simply a living document that will evolve over time and build upon itself so as new areas develop for the patient. The Care Compact can develop mutual respect. Too many times I will hear a physician say to me, well, I don't even know what this physician is thinking about. And, you know, I ask them, well, have you thought about asking them? You know, have you thought about documenting some communication processes so that you have ways of exchanging ideas? So this builds mutual respect to build a sustaining relationship and work collaboration. And a high-functioning medical system of care provides patients with access to the right care, the right time, and the right place. And again, I can't emphasize enough as we move into risk-bearing contracts and into highly clinically integrated healthcare systems, that alignment of specialists and providers and that communication alignment is critical if we're going to share in the success of our work. So again, some of the benefits is patients experience coordinated care that adheres to their needs. And I can't emphasize that as probably the most important piece of our care compact. Patients are more likely to avoid unnecessary or duplicate testing. Providers are able to collaborate and share information. And they facilitate improved efficiency and development of tighter networks of trusted high quality partners which again is important as we move into value-based contracting. So what are some of the types of care compacts that we're looking at? And a simple one is just the pre-consultation exchange or communication between two providers. And with this, it often is not a written agreement here, but this is often just one specialist or one primary talking to a specialist, answering and asking some clinical questions to determine the necessity of a formal consultation. Is this something that the primary care physician can handle in talking with the specialist? This also helps to facilitate timely access and determine the urgency of a referral to a specialty care. This can help us facilitate the patient diagnostic evaluation prior to the specialty assessment. What testing would the specialist like the other physician to perform for the patient before they actually get to the specialist? And it's rare today that you see a physician pick up the phone and talk with another physician. Just doesn't seem to be the time there. So the notes from the referring clinician are critical. And the specialist physician that is receiving those notes needs to be sure they have those notes before they see the patient, and then they need to read them. Many times I've had patients tell me that they've gone to the specialist's office assuming that the physician has communicated in some way, shape, or form, only to get there and be asked, why are you here? And of course, patients are not always very well informed as to the technical issues of their care, and so they often can't describe very accurately what it is they are here for. And so this is very frustrating to patients, and it also can be wasteful in that tests and other diagnostic procedures may be repeated, and there's not that communication there. So it's very important that the primary care physician or one specialist to another specialist has information documented, and with test results and diagnosis and findings and medical history, and that information is then read before you see that patient. There's then the formal consultation that we have here, and this is the request for an opinion on a discrete question regarding the patient's diagnosis or diagnostic results, a procedure or treatment. And what we see in the formal consultation, this is sometimes what we used to call our referrals, and that we sent the referral over to the physician. But with this, we also expect the specialty practice or the other specialty physician to provide a detailed report on the diagnosis along with care recommendations. And so this again is who will then take care of what aspects of this patient's condition. Will the specialist or will the primary care share in that? This could be an example of a formal consultation, could also be in the surgery, a surgery request. Maybe it's a dermatology request. And this is then asking for the patient to be transferred back to the PCP after one or a few visits. And so this report will also include an opinion on the appropriateness of co-management. Is this going to be a complete transfer of care to the specialist, or will the patient come back to the primary for some parts of the care? And again, this is an important piece of this document, is to articulate those communications. So when we have a co-management or a shared care, you're having two providers that are going to actively contributing to the patient care. And so the responsibilities in this document is how often is the physician going to see the patient? An ophthalmologist who's maybe referring to a retina specialist because of something that the ophthalmologist sees on his exam is requesting the retinal specialist to give an opinion to treat if necessary, but the ophthalmologist would still like to follow up with that patient on a yearly basis. The determination in co-management is who's going to manage the drug therapy. It may be very clear as in the case of referring to an oncologist as to what the oncologist is going to provide in terms of drug therapy, but there may be other things such as routine colds or other conditions that may come up with that patient. Will that primary or the other specialist then take over managing that particular patient's conditions? Diagnostic testing. Who's going to provide the patient education, and what kind of patient education will be provided? Who will manage what pieces of medical conditions? Who's going to monitor, and how is the patient follow-up going to happen? This is especially important when we have the impact of medication. Sometimes certain medications with specialists will interfere with blood pressure medications or diabetic medications, or if the physician wants to order antibiotics, they may need to check with the specialist to see what type of precautions that they should use in managing this. So again, the literature is full of the gaps in care, the mistakes, the falling through the cracks, if you would, when patients have multiple providers. So this care compact, is one way in which we can bridge those gaps and provide for better outcomes for our patients so they're not having complications of medications and they're not having duplication of services, which can be costly. And again, I'm going to go back one more time and say that as we move into our value-based contracting, as we look at integrated care, it needs to be aligned. And so these care compacts are a good experience for us if you're not already in a clinically integrated risk-sharing situation. You probably will be at some point in the near future. So beginning to realize the importance of this kind of collaboration is really important. Then we have a situation where you're going to do a complete transfer of care to the specialist. Maybe due to the complexity of the patient's condition and diagnosis, the specialist is going to assume total care, full contact, ready access, continuous care, comprehensive and coordinated medical services, and links to the community resources. So I don't know if any of you that are on the line there, if you want to give me an example of what you would think or maybe you have seen or you're involved with a complete transfer of care to specialists. If you want to just stick something in that chat line there and let us know what kinds of examples that you have seen for complete care. I think probably what comes to mind for most of us are in cancer care treatment, where patients are transferred over to a specialist group that are dealing with that patient's cancer treatment. So if you think of any others, please go ahead and put them in the chat. We'd like to share what you may be experiencing as well. So what are we going to do? How do we set this up? How do we go about introducing care compacts into our practice and with our physicians? And so this is an important concept to keep in mind here, is that we first want to sit down and identify the communication gaps that are already existing within your practice. What are those challenges that you want to address? I think every practice who has referred any patient at any point in time can sit there and tell you what are some of the frustrations that they see in the referral process. And not every patient is going to need a care compact, so we want to keep that in mind too. This is not a situation where you may need to do it with everybody, but you also need to align your objectives, identify your challenges, and how the care compact can address those. And I think I'm working with a physician, internal med physician, who is specializing in weight management and in hyperlipidemia conditions, metabolic conditions. But he does not want to be the primary caregiver for these patients. So we've put together a care compact concept for him so that he can share with the patients what his role is in helping them with their metabolic process of weight, and then what is the primary care physician or the contact that he has with their primary care physician to state in this compact what that primary care physician is going to be responsible for and what he, as the specialist, are going to be responsible for. Establishing that communication and that respect for each other, because often the medications that he is prescribing for weight control may have an impact on hypertension medicine or their diabetes medicine. So he wants to have that dialogue and that communication with the primary care physician without treating those things himself. So this is an example where a care compact is really important, and the patient needs to understand that this is an important part of their care as well. And so the second thing is you want to be able to articulate your measurable care goals. This will enhance the provider accountability and by establishing your very clear short and long-term goals for the implementation of your care compact. Because once we can see that we're meeting our goals and eliminating some of these gaps and challenges that we've had, then it's easier for people to adopt and stick to the documentation process of a care compact. I'm going to show you an example of a care compact template, and so you can see what that looks like as well. The other thing that comes up all the time when we're talking about care compacts is what about the patient who self-refers to the specialist? So the patient shows up at the dermatology office. Had this recently happen with a physician practice, a patient. They referred themselves over to dermatologist's office. They thought they had an allergic reaction to something, and turned out that they had a pretty serious staph infection. So the dermatologist treated this infection, and the patient was then asked to inform their primary care physician of the care that they received. And this is, a pretty significant piece of information for a primary care physician to have concerning a patient's pretty extensive dermatological staph infection. So sometimes what you may want to do as a specialist and you have a patient that self-refers is put a line on your consent form as to who is your primary care physician, and may we send information about this visit to your primary care. Knowing again that we're trying to encourage that interdependency and intradependency here, that having that information flow between the specialist back to the primary when a patient has self-referred is an important piece of information as well, as we're striving to treat the whole patient. So again, we talked about informing and including the patient, and this is really, really important because the patient needs to understand, and of course, for those of you that are into the coding piece of this, you know that 2019 ushered in some codes that we can use for Medicare for consultation purposes. So there is even greater encouragement from CMS side to really have these care compacts, because then it gives you an opportunity to bill for those consultations that you're having between physicians. But as with anything that we bill on the Medicare side, the patient always has to be aware that that is taking place. And so it's important to inform and include the patients and to educate the patients on the purpose of this and to avoid overlapping care. And that is part of the physician example I gave you on weight management. He's very clear with the patients, and if it's a referral from primary care, he's very clear with them as well that these are where the boundaries are going to be. We're not going to have overlapping care. I'm going to make suggestions of changing maybe blood pressure medication. I may ask the primary care if he wants me to change the blood pressure medicine, or since I'm not monitoring the blood pressure medicine, then it should go back to the primary care physician. You also want to educate and train your staff so you can foster a commitment on your goals of your compact with clear documentation standards and efficient task distribution. We're going to talk a little bit about flow mapping. And then you want to audit your changes. You want to assess the progress to your compact adherence. Going back to your first step of identifying your communication gaps and aligning your objectives, you want to be able to audit and say, have we contributed to improving on the outcomes and those gaps, and have we better aligned our services with the specialist. Now, this little diagram will show you a map workflow. And I believe that mapping your workflow is one of the most powerful tools that you can use in any office or practice process, because a mapping your workflow brings clarity. It shows where you may have overlap in your process. It displays your gaps. You can look at your steps in the process. Are they necessary or not? It gives the staff and the providers a visual aid of the flow, and it really defines roles and responsibilities. So I'm a big fan of mapping your workflow, and you can also do it with swim lanes to show roles for staff. And so this is just a very simple diagram of what happens in a referral flow and who's responsible for which piece of it, and what happens in the event that the patient doesn't follow through, and what are your next steps. So I'm a big fan in workflow mapping. I think it really helps your processes within your practices. So this is a typical, you may not be able to read this too well now, but if you download and have a copy of the slides, you can see this. This is an example of your collaborative care agreement or your care compact. Again, the words that you use to describe it just need to be meaningful to you and to the people, to the specialists that you're referring to. And you can see where this one has outlined the primary care responsibilities and outlined then the specialty care recommendations and responsibilities as well. So this helps to improve on the communication. And sometimes if you're in a multi-specialty group and you have the specialist and maybe you're sharing the same electronic health record, that makes this care process and this care compact even easier, because you can articulate this communication within the same electronic health record, and you can then be sure of who's going to take responsibility for what piece of this person's care. I can't tell you how much this really means to the patient to know who's responsible for the care and who are they supposed to go to with what question, and who's going to assume responsibility for that. It also helps prevent the patient from playing one physician off of another as well when it comes to getting things that they may want but are not necessarily good for them. So when we're looking at the ideal handoff, and you can either read this across or down, what you're looking at is the practice makes the referral to the specialist, using the compact agreement. And if we're going across, then the patient is prepared to see the specialist and is prepared to know what to expect. And the specialist may work with the primary provider on the workup prior to the visit. So there may be some things that the specialist would want the primary care physician to do before they see the patient. And so the practice may conduct that workup based on the agreement, and the patient makes the appointment based on the urgency. And then the specialist office ensures that all the documents are received prior to the patient visit. There is nothing more frustrating to a patient than to think that all the information is there, only get to the specialist, and nobody can find any of the information, and they're not sure what's been done. And one of the other consumer surveys that I conduct for practices and health systems is on no-shows. And one of the biggest reasons that patients will tell me they no-show is because they see no value in the visit. So when a patient is referred and goes to a specialist or to another physician for whatever reason, and information is not there or hasn't been looked at, and so the patient doesn't really gain from the visit what they thought they were going to gain, this becomes a visit of no value. And so it's really important as we look at value-based care and healthcare today, and as we look at reducing costs, and we know patients are responsible for more and more of the costs out of their pocket. So to go to a visit where the information is not there and you can't really accomplish what you thought was going to be accomplished, and that goes back to this middle section, the patient is prepared to see the specialist and what is the expectation, So an ophthalmologist recently referring a patient to a retina specialist, ophthalmologist in the process of the exam saw something he thought he didn't like in the patient's eye and wanted them to go see the retina specialist, informed the patient, this is the physician I want you to see. Here we make the appointment. I'll make sure all of my documentation is sent to the retina specialist. The patient gets there and they ask, why are you here? And the patient who doesn't know what it was this ophthalmologist saw in his eye, he saw something in my eye. And the documentation is not there and or they can't find it, they can't read it. At that point, the patient has paid an out-of-pocket copay, usually higher for a specialist, and does not get the information that they expect because the information was not there for the specialist to review. Or the patient goes through all of the testing over again that was already done because the documentation is not there. So when patients are expected to be paying more and more out of their pocket as they are today, and they're looking for value, a high reason for no-shows of not following through is the fact that they see no value in it. So we need to pay attention to that, especially since the patient is paying more of the bill. So then we see that's, again, the specialist office makes sure that all the documentation is there and that it is read. So the patient, the office makes sure that all the information is sent over. The roles and responsibility of the primary and the specialist are clearly explained to the patient at their activation level. And by activation level, we're referring to the knowledge, skill, and confidence that a patient or consumer has to manage their health and their health care. So sometimes our patients, when we refer them, if they're in a lower activation level with not a lot of knowledge, skill, and confidence to manage their own health or health care, need some assistance from us to make sure they get to that specialist office and that the information is there. So the specialist will see the patient, the referring practice tracks the status of the appointment and the follow-up. The patient is aware of the recommendations, sees this as all part of the care plan. We have to get our patients, especially our patients that have comorbid conditions, we have to get them used to the concept of care planning. And we know that we can charge for chronic care management, collaborative care. There are things that we can charge, but the patient, from Medicare side of view, has to be aware, has to be some documentation of consent because copays apply. But we need to have our patients understand that care goes on outside of that visit and that there is reimbursement for that belongs to the physicians as a result of this collaboration of care. But the patients need to see that there is a care plan and that this care is being collaborated. So the specialist consults with the patient, referring to the compact, and makes recommendations based on findings. The practice incorporates the specialist recommendations into the patient's care plan. The patient is provided with education and resources based on their activation level again. And the consult has a summary and a plan returned to the primary care per the compact agreement. So this is the ideal. This is what we strive for. And we know that we don't always hit the mark, but this is what we are striving for in our new world of value-based healthcare. So just a little bit of a summary before we open it up. And while this topic is probably not as long as other topics that we may have webinars on, I want to give plenty of opportunity for people to share their own examples of things that they've been doing with care compacts or care agreements and some of the challenges that you may be experiencing. So the Care Compact, what it is in summary, is that it's promoted actively by a lot of our national entities, including our NCQA's Medical Neighborhood. It's an agreement that outlines guidelines for providers of coordinating care at the process to ensure the safe transition for care of members. It promotes mutual trust while improving communication. I can't say. There have been numerous times when I've been in the specialist office and they have not been complimentary of maybe another physician with respect to what they did or did not do when they sent the patient there. And of course, my comment to them all the time is, well, what kind of communication and agreements do you have with each other? If you're referring patients back and forth, maybe sitting down and spending some time to create some care agreements and care compacts so that the physician knows what it is that they expect. You know, this happens a lot in gastroenterology when you're looking at colorectal cancer screening. And what is the communication that you want the patient to have, and how are you going to make sure that the primary care or the other physician understands what it is that you expect? It's not going to happen without some communication because, again, they don't rub shoulders in the staff lounge anymore like they used to. So there was far more communication between physicians and respect for each other than I often see today because we have hospitalists and intensivists. And so that physician-to-physician contact between specialists or between primary and specialists doesn't exist in the same way today. So now we need to resort to things like care compacts and care agreements. And so what it does also do is it outlines and defines care episodes, expectations for roles, responsibilities, and data exchange standards. It's a set of standardized processes for referrals and care coordination by outlining data requirements for status updates and patient profiles. Now, what it is not, and this is important, when one physician, primary and or specialist, sends a care compact to another physician or specialist, this is not an agreement between the specialist and that patient. It's merely a communication that the primary or the specialist sends to the other physician to share in their observations their knowledge of that patient and what they would like to see that specialist, but it is not any type of an agreement between that patient and the specialist that's being sent to. The care compact is not a replacement for what the health plan medical management guidelines. You still have to follow. If you're sending to a specialist, you want to make sure the person is in network for the patient. That's important. And so it doesn't replace what the health plan management guidelines are. A care compact is not a defined set of clinical measures. It's not telling the other physician, these are the clinical guidelines for you to follow. And it's definitely not defining reimbursement. Okay, so that needs to be clear as well. So there's lots of resources out there that can assist you in putting together the care compacts. Colorado is working on medical home neighborhoods with our state innovation model, and we use care compacts between physicians, between specialists. We're especially using care compacts between cardiology and primary care and gastroenterology and primary care. And it's also really important when you're in maybe smaller communities and rural communities, and maybe your primary care physicians or your specialists, extend beyond the services that you might find in a larger city because things are just not as available. So you can define, who's going to do what in the relationship with the patient. So at this point, I just want to kind of open it up to everyone and see if there's any questions.
The leader has unmuted your line.
Feel free to share your examples as well.
Hi, this is Michelle from Intelligence. We ask that you all mute your lines in case there's some feedback there. Thank you so much, and until you're ready to ask your question. Pam, thank you. That was a really great presentation, very helpful and explanatory. And so now let's see what questions everyone might have.
And I think if anybody has any examples of how you're conducting your own care agreements, your own compact, feel free to share those with us as well. We'd like to hear what your experiences have been with this type of procedure as well. maybe we can ask for a vote in the chat line here. How many of you, by saying just yes, yes, are actually using care compacts or care agreements in your practices? And in the chat line, can you just say yes, no, so we can kind of get a feel? I guess we should have put a polling question up for that.
But I was just thinking that, Pam, sorry.
That's all right.
Everyone, the chat function to enter that in would be the little blue circle at the bottom with a little bubble, I guess, there to enter your answer into the chat function.
I think someone is saying they were unable to see the link for the slides. Was that visible now?
Yeah, I've been
unable to see.
Trying
you
to
sent that
post
to
that.
them.
Yep. It looks like Kathleen Randolph has said not with a written plan, but yes, we are doing.
Okay.
And Karen has said yes. They are.
Some of them have not used care agreements. Okay. So Kathleen, do you want to share with us? You say not with a written plan, but yes, we are doing. Kathleen, why don't you share? Can you share with us if you're there how you are putting that together? Then, what type of format are you using? Are you maybe documenting something in electronic health record? Is Kathleen there? Kathleen Randolph?
Please, so Kathleen, if maybe you have yourself on mute.
And here's here's another one, part of an ACO. So they've guided us through this process a few years ago. That's important, again, from an ACO and a value point of view. You need to, again, the question there is, are you assessing the effectiveness of this? And are we looking at the gaps in care through the ACO, as someone in the ACO, looking at those gaps in cares and assessing if the care compact is meeting those gaps and how well it is improving the outcomes of the patients and also patient satisfaction? You know, this is a question to ask patients. How coordinated do they feel their care is among the multiple providers that they may be seeing? It's a question I often am asked to ask consumers and patients in health systems. One I don't get a lot of high marks on. So this is an important piece when you're participating, is to make sure that you're assessing the effectiveness of it, the value of it. Everything is value today, right? Value, the intersection of the cost of doing something and the outcomes of it. And your number one ACO in the country, that's great.
Pam, we had a question. Somebody said, thank you for your presentation. And would Privia Health be an example of this type of physician's work arrangement? And that was from Eliana.
Okay, Eliana, I can't say that I'm thoroughly informed on Privia Health, so I'm not sure that I can answer that question accurately for you. If somebody else is more aware of what Privia Health does and how they do it and wants to answer that question, please jump in. Another question, do you think that this issue will improve with the new PI measures, the performance interoperability measures with the MIP? I think electronically, we would like to use care compacts electronically between providers. Ideally, this is the world we want to enter into and move to. So we're hoping that if we can improve performance interoperability between electronic health records. After all, we can bank all across the world with one ATM machine. I'm sure we can figure out how to get our electronic health records to speak to each other. it would certainly be an improvement to be able to share that. I mean, I'm certain there are ways that you can still send some of your care compacts electronically into electronic mailboxes of other providers if you're connected. And closing the referral loop, this is closing the referral loop at a higher degree. You know, at first when we started talking about closing the referral loop, it was, are you sending a referral? Are you getting a response back? Okay, so now we're talking about even going a few layers deeper here. We're talking about really delineating out the care between one provider and the other and improving on that communication between each other as if we were standing side by side talking to each other. So electronically, we hope we can do that. Okay, so Michelle, if we don't have any other questions, you're always welcome to contact me directly. My email is up here. I'm always willing and ready to accept any questions that you might have. So feel free to email me with those if you want to talk about it offline. And we want to give you some time back today. That's always good. So that you can have 15 more minutes to answer some more of your emails.
And thank you again, Pam, for this very helpful and I think quite timely topic, as this is a very big piece also for MIPS, but also for those looking to join an ACO. So we can't thank you enough for all of your time. And again, if everyone wouldn't mind, please completing the survey after you log out here, we would greatly appreciate it. Thank you and have a great day.